Yeah, good evening, everyone. Today we are dealing with a very important topic, particularly for we anesthesiologists. This is a very difficult situation, and to put some light on it, we have today Dr. Lalisha. He is a consultant urologist. Hello. Sir, you can start.
Okay. Uh, Good evening, everyone. Thank you very much for giving me an opportunity to share my thoughts on death on operation table. I'm very much thankful and grateful to Dr. Mahesh Sinha. It is a pleasure and honor to be amongst the learned audience. Death on operation table, the term per se, the name per se is such. The moment you read it, the moment you hear about it, the moment you think about it, the death on table or half death on table, whatever experience you may have had in your life, maybe 10 years, 20 years, 30 years, 40 years, that come just like an action TV replay in front of your eyes, and you miss couple of your heartbeats. Till today, it happens with me. I do feel tense. I feel those, remember all those so-called half death. Fortunately, I never had the DOT, but did have an experience of 3, 4 half DOT where we have been able to revive them. And unless until you are a very thick-skinned money-making robot, कि जिसको किसी चीज से कोई फर्क ही नहीं पड़ता. Now, the critical incident in operation theater can occur. Either you have a successful reversal where the patient has been reversed into 100% reversal, or it can be a partial reversal where though you have been able to revive him, but probably the time taken was a bit longer and there is an hypoxic brain injury. Or the third one situation can be where you have not been able to revive in spite of all your best possible attempt. So why are we talking about it now? Because the surgery, the anesthesia, the death on operation table, these have been happening since centuries altogether. This we are talking about since maybe last 20, 30, 40 years. That is because of this new law that we are having, that is the Consumer Protection Act, litigation, and the changing medical legal scenario and the social scenario in our medical practice, the so-called violence and all that. That is why it becomes important, and it is very, very that we need to take care of this. So is there any standard protocol? There is no standard protocol. Like I said, this is going on since so many years, but we talk about this only now. But in general, whatever we have been saying, it has been my experience that whenever we are talking about this, we always feel that this is not going to happen to us. Though the subject is good, the talk is good, everything is fine, but fortunately, it is not going to happen to us. In maybe 20, 30 years of my practice, it has not happened. In further practice, also, it will not happen. Even it will happen, we know so many of the Munna Bhai and Ajar Bhai and all that, and we will take care of all these things. But it is very, very important that we learn the nuances of this. And whenever I say you, I mean we, and I am very much included. That's a disclaimer. See, the problem is that this can occur in a different scenario. The first one, it will be unexpected, unpredictable, and unavoidable. I mean, that will be the situation which will probably happen even if you are operating on your mother, father, brother, sister, uncle, anyone there. And another category is a high risk patients where, say, for example, if some person is having ejection fraction of 15, 20, 25% and all this, a very old person, multiple comorbidities and all that, the patient's attendants are also understanding, and the surgery is often a nature that has to be done in sort of emergency or a semi-emergency nature, where they are also mentally prepared, and if it happens, there is not too much of a hue and cry. And then the third part is, which happens is because of the preventable medical errors. Now, the fact is that unfortunately, if the death occurs, whenever there is a death on operation table, now let us forget about the high risk cases. In these two cases, even if there is a preventable medical error on the doctor side, doctor would always try to insist that this was unexpected, unpredictable, and unavoidable. And even if it is of the first variety, that is unexpected, unpredictable, and unavoidable, the patients and their attendant, patient will be, of course, no more, but their attendant and, of course, the media, etc., and all that, they would always say that it was the doctor's negligence and a preventable medical error. So, when the matter goes to the litigation, your word against his word is not going to work because that neutralizes. And the only thing which is going to work is your medical records. The common thing when it happens is that there is a total blackout in our mind, and we always feel, oh God, hey Bhagwan, mar gaye, ye kya ho gaya? So it is very, very important that because you are the leader of the team, see, in the medical institute or a bigger hospital, it is different, but at least 80 to 90% or 85 to 90% of the Medicare is being provided in the small and the medium nursing homes, where there may be anesthetist, surgeon, maybe another one, or a helper, and the OT staff. Not too many people will be there. So the surgeon is the leader of the team. If he is going to panic, it is going to create a problem. So if you can say few data are there, that millions die from surgery. This is a WHO report in 2008, not now. That every year there are 234 million surgeries and 7 million preventable surgical errors are there. So 1 million die during or after surgery. And the worst part, as per that data, is 50% of the injury or the death are preventable. This particular thing is very, very toxic. So now the scenario is different in a small and a big hospital. In a small hospital, if there is a death, it is going to create more problem. But in a medical college hospital or a bigger corporate institute, if it is happening, probably the trouble would be much less. Similarly, about the high case and low risk case, and similarly about the cold and emergency cases. In emergency cases, they are mentally prepared to a certain extent that the things may not lead to too much of further litigations or violence and all that. But say, for example, if you are operating on a kid for some small procedures, maybe a hydrocele or something, and if that unfortunately there is a death at an operation table, for a small nursing home, it is going to create a lots and lots of havoc. So these are the sequence of events. The patient coming to your OPD for the surgery, everybody wants that. We do the pre-operative assessment, pre-operative preparation, informed consent. That is what we do. And it is then the anesthesia is given. Till that, everything is going on smoothly. And unfortunately, then the death on operation table occurs. And then it can lead to consequences like spot violence or police complaint, consumer forum, civil suit, or medical council litigations. See, the spot violence is something which is basically it's a law and order situation. So it is very, very important that I have always been telling in whenever I am talking about this or any other medical legal topics, that it is not only important to be a good clinical diagnostician, you should also become a reasonably good social diagnostician so that you are able to diagnose the trouble possible case. If there are too many attendants with someone, if there are not too many attendants, or various class of people, depending on your risk-taking capacity, you can always try to avoid where you can anticipate that there can be a trouble if something goes wrong. It is much better that you take care of the 99% of the patients and leave about 1% of the patient for some referral to higher one, without any shame, without any fear that, okay, my hospital is small, I am a small person, it is better you go to a higher center. And then it is very, very important that you should have a dedicated group. The dedicated group has to be in the your area only, in that area, so that whenever there is a problem occurring or you are anticipating a problem, you call one friend. And your group should be such that you don't need to call 10 people. You call only one, and then he is going to call the other 10 people so that they will come. It is possible that everybody may not be able to come, because they may be, if somebody is operating already, he cannot come, leaving the surgeries. So it all depends what to do, but at least some people will be coming who are nearby. And then, of course, the people from other part of the city, which will take little longer to come, they can come. And if you are anticipating that there are problems, there is creating a loss of and all that, it is much better that you inform the police that something has happened and there is a possibility of a violent situation here. So please come. Another thing which we have seen is that many times there is a spot violence and all that, but the doctors are, I do not know the reason, but doctors are afraid to lodge an official police complaint. They do not go. If at all, even they lodge the official police complaint, they do not take the follow up and all that. That is what had been our experience. How do I do move that? Then it is very, very important that in the hospital and even in operation theater, we should have a CCTV camera and the security people there. The CCTV camera, of course, because of the private privacy things and all that, CCTV camera cannot be put into operation theater main, where everything is being seen and all that. But those who are entering, who are not entering, that part, hiding the identity of the patient, the CCTV footage should be there so that it is there. Delhi government has now put so many of these hospital bouncers are there. Though there are Prevention of Violence Against Medical Establishment Act in more than 20 of the states, but unfortunately, in spite of giving the sufficient proof, the video recording, CCTV footage, and everything, and in spite of having a reasonable connection with the police officials, they do not register FIR under this act. I do not know, because everybody is having sympathy with the patient and their attendants, and they are against the doctors. So if there is a property is damaged because of the violence, photograph of the damaged property should be there. Injured staff, a medical checkup should be done, and treatment, all these things preferable into the medical government hospital. The furniture insurance and indemnity insurance should always be there. That is very, very important. Now, another thing which has been occurring beforehand was that once there is a death in the operation table, the attendant will go to the police office. This was happening more than 20, 25 years ago. They will go to the police station, they will file a complaint, police will come and arrest the doctors. While the Supreme Court has already given in various, this one, Suresh Gupta case, Jacob Matthew case, and Martin D'Souza case, Supreme Court has given a very, very clear-cut guideline that the doctors cannot be arrested just like that. Even if there is a complaint against them about the medical negligence of criminal nature, the medical board should be formed, preferably in the government hospital, and having at least one specialist of that specialty which the complaint is against. Say, for example, if it is anesthetist, the medical board cannot be without an anesthetist. An anesthetist must be there. And and in Martin D'Souza, they were even said that if the police is not behaving in a proper way and is arresting the doctor without the medical board, there can be action against the police. But the one thing is there, Supreme Court ruling is one thing and the ground realities are different. So it is very, very important that we must have copies of these judgment with us so that when the people are coming to arrest you, you can show that you should not or you cannot unless and until there is a medical board and it says that there is a prima facie negligence from the doctor's side. In this decision, they have said that their criminal negligence should be gross. Though in our IPC and now they change into the Sanhita, that Indian version which has been changed, the word gross is not there. See, one of the most important things that I have been telling every time is that the medical field is the only thing which is having something different. Say, for example, I am giving a talk and you don't like me. You don't like the talk, mata kha gaya. So you can come to me here and you can kill me, and there would be only one case against you, that is a 302. All right. But if you operate on one of my family member, and if I'm not happy with you, then I can file cases at multiple places. Civil case, criminal case, to the nursing home, consumer forum, medical council, Ministry of Health, everywhere it can be filed. And that is why I said that it is much better that you call the police before they call you. Now, that is something which, if the violence happens, that is the one thing. In the operation table, if it has happened, then we have to take care for the resuscitation. The resuscitation means it will be taking a 6-step management. First of all, most important thing is that we must understand and accept the very fact that the critical incidence has occurred. We normally, it becomes very difficult for us that especially when it is an unexpected type of thing, that we are not able to accept that this has happened. And that is what is the important thing. So that we must do the rapid assessment of ABC, airways, breathing and circulation. And the most important thing is, in a corporate hospital or medical college, the help is around nearby. But whenever you are working in a small nursing home, then we must keep our ego aside and call for the help immediately. We must get some surgeon help also. We must get some anesthetist help. Whosoever is free, they can come and help you. So they will help you for the assessment, for the management, and for the record keeping, because those persons, especially the surgeon and anesthetist who are primarily involved in this particular case, will naturally will be not in the 100% exact frame of mind, so that a new brain who is coming will be in a better position to see to it things. And surgeon should stop operating if is possible. Assessment and treatment to continue following the ABC by the appropriate protocol. And at various stages, it is better to pause and reassess the ABC. And of course, if your friends have arrived, anesthetist and surgeon and all that, it is better to have a fresh eye for reassessment, because their assessment will be much better than the assessment by the person who is involved. And of course, the most important thing is the completion of records, because completion of record is very important. Because if unfortunately the police comes and they are going to come do the seizures, then they would be taking over the record. If your record is incomplete, it will create a problem later on. So the important thing is that we should be prepared. Preparedness of this, that this can happen. So most important, don't panic. Let us have a fixed protocol so that we understand that in case the situation happens, who is going to do what. Otherwise, what happens, whatever the nurses are there or the staff is there, everybody is doing just trying to do the same thing, and the energy is being wasted. Of course, mock drill and all that is the best possible thing which can occur in the bigger hospital. But in a smaller hospital also, for small things, few practical tips can be done. It may not be as good as in this one. And like I said, getting the help of our colleagues is very, very important. Because if because of anesthesia problem, he has gone into arrest, it is much better that a second anesthetist is also available to help him out. And of course, we must do the training of the staff. And very, it is important that our training of the staff should be such that they are not supposed to talk. They are not supposed to talk. Many times it happens that because of either vested interest or innocence, they may go out and they say, no, 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 patient का हालत बहुत खराब हो गया था. The patient has gone into cardiac arrest और अभी हम revive कर लिए हैं. Patient अभी ठीक है. भगवान की दया से सब ठीक हो जाएगा. So, and another thing is that you should communicate to the relatives gradually. If you are going to say all of a sudden that, okay, now the patient is no more, it is not going to be accepted with this one. So you tell that this thing has happened. We are trying to do the revival and we have revived. We have been able to revive the cardiac rhythm. We are giving the artificial respiration by the intubation things and everything, whatever is there. And if possible, it is better to get some relative in OR so that they are able to see your attempts. Because otherwise, in the four walls of the operation theater, they are not allowed inside, so they do not know what has happened and what attempt you have made to for the resuscitation. So if then of course you should not bring out any relation. You should bring only the relation with whom you already had a pre-operative rapport with the patient. Surgeon or anesthetist, whosoever has a better rapport, he should call this that okay, this is happening, this is happening, this has happened. We have done this, we have done this, we have succeeded in bringing back the cardiac rhythm, etc., whatever is there. Like I said, communication to staff is very important because if they go out and say something else, it will create a bad confusion. Before calling any patient attendant into the operation theater, it is better to do the setting of the operation theater. See, we may be used to the blood, all this, and we know that few blood here and there, which may be seen, may or may not be, say, 200 or 500 ml. But it is not going to cause a panic that this is the cause of the bleeding and the cause of the problem to the patient. But any stranger, whosoever is coming, who has not seen the blood like this, is going to create a problem. So it is better that you put up clean up the OT to certain extent, cover up your drapes in such that they do not look too bloody and all that. Another thing is oxygen cylinder. Oxygen cylinder is a very tender point. Your oxygen cylinder not having an oxygen and the patient's attendant are coming inside the theater is a very bad thing and a very bad impression because because you may know for maybe for a 1 minute or half minute, if the cylinder while changing it is not there, it may not create too much of a things as far as the basic prognosis is concerned, but the patient and attendant would always feel. Another thing is very important is the you check along for the endotracheal tube that this is not in trachea, that it is in trachea. I'm sorry for the stutter, that it is in trachea and it is not in esophagus. Take care for the mop down. And another very important aspect is if the police is going to come, they are going to take the seizure of everything whatsoever is there, all these ampoules and all that. So that if there is an expiry date drug, we all can understand probably the expiry date drug is not going to become toxic. कि रात के 12 बजे तक तो कुछ भी प्रॉब्लम नहीं है, 12 बज के 1 मिनट के बाद वो जहर बन गया. It doesn't happen like this. But there have been cases where the doctors have been in trouble because of the expiry date drugs. So it is very important that you check that there is no expiry date drug there. And adrenaline is one which has a very short expiry date. And most of the time, if you check in your operation theater, the commonest expiry date drug will be the adrenaline. So please take care for this. Another thing is that whatever has happened, you try, say, for example, in spite of best attempt of yourself, your friends, your colleagues and everything, whatever you could do, you have done, and unfortunately, it has not worked out. Now, in that situation, if it is not due to the surgical cause about the bleeding and all that, if it is because of the anesthetic situation or general situation, the commonest cause that you would be giving is either a cardiac arrest or an anaphylaxis. All right. So, in that frame of mind, probably the sequence of the medications, sequence of the treatment that what you have given may or may not match with the books. But that's okay. Whatever you have done is it's fine, fair enough. But in record, you should have a proper one, so that you should have the textbook recommendation about the medical management, about the sequence of drugs that you need to give for cardiac arrest and anaphylaxis. That should be photocopied and pasted in the operation theater wall, so that whenever you are writing the records, it is written as per the books one. So that that is your documentation should be 100% proper and it should match the textbook. And another thing which has commonly I have seen at many of the places is that they have the habit of writing. A nurse will come out and give a prescription कि pharmacy से लेकर आ जाइए. That practice should not be there as far as the operation theater materials are concerned. That practice may be okay for the outpatient or inpatient where the cold treatment is being done, but for emergency drugs should be there in the hospital itself, in the operation theater. You cannot come and say, okay, भी एक डेरिफाइलिन ले आइए या एक एड्रेनलिन लेकर आ जाइए. That will create a very, very bad impression and it will be a very toxic situation if the matter goes to litigation. So you should have your this one. No prescription for emergency drug should ever be given to the patient. And then, if possible, it may or may not be possible for a very small hospital which are having a limited staff. But if it is a possible, then you should have an emergency staff team, a separate emergency staff team. In general, in a smaller hospital, what is being practically done is that except for one or two people who are outside, everybody else come to the operation theater and help the people. And there should be a fixed protocol for CPR under the leadership of the anesthetist. Of course, anesthetist and the operation theater is the best possible combination for the resuscitation. There cannot be anything better than that. So that there is no confusion there. And every member should have their role defined. So that if the CPR is being done, not that any nurse or compounder, whosoever is coming, is trying to put his hand, unless until he has been requested by or ordered by the anesthetist to do that. Another thing, when the case has occurred, say for example, and whatever is the result, say for example, the anesthetist needs emotional support after the critical incidents, whether you have been able to revive, whether you have been able to revive partially, or you have not been able to revive. So, if possible, it is much better, especially in the private setups and all that, that he should not take any routine cases for at least 24 hours. He should stop his day enough for the day and should call it a day. This may not be very practical or possible in a government institute or maybe in the corporate hospital, but in an individual practice, roaming practice, the individual doctor should not take that, because second critical incidents within 24 hours may not be as detrimental to the patient as it will be to the anesthetist. So that is very, very important that he should take care for this. The surgeon, another thing is, many times it happens to do or not to do. Say, for example, you have taken a patient inside the theater, you are given anesthesia, just started anesthesia, and the patient goes into cardiac arrest. And fortunately, with your expertise, you are able to revive it 100%. So maybe after 10 minutes, the surgeon feels that, okay, there is nothing wrong in that, we will proceed with the surgery, because he has a long list for today, he has a long list for tomorrow, and he does not want even to tell to the patient or the attendant that such thing has happened. He would try to probably brush it under the carpet. That is the general tendency of the surgeons, and I am not excluded in that. Without any shame, I'll say that we would try that, okay, we will not talk about the cardiac arrest at all. Patient आया था, revive हो गया, हमने operate किया, वापिस आ गया, सब ठीक है. So it is very important that if the cardiac arrest has occurred and you have been able to revive, not to do the case, not to do the case at least for 48 hours. And another thing is, should surgeon continue the next list? Like I said, surgeon is a different thing. Like in my private practice, whatever my experience was there, like I told, four half death we were able to revive. I cancelled all my cases for that particular day, told all the people and the patient and their attendants that okay, you it was my own nursing home, you stay one day extra, you don't have to pay anything extra. And it has happened, and I am and my anesthetist both are not in a positive frame of mind to take care and do the honest judgment, and patients and their attendant understand, provided you are not charging extra for one day. And this thing, like I said, may or may not be possible in the government hospital and all that, so everybody has to take their own call. And another very, very important thing is that the surgeon and the anesthetist, see, they should, whenever the matter has gone for the litigation, or whenever you are talking to the patient's attendant and all that, you should work like a team. It should be the sharing the responsibility, and they should speak the same language, and they should not fight. I have seen many of the cases since last 15 years. I am dealing with these sub cases and helping my friends and colleagues in more than 350 cases. I have realized many times that the surgeon says, भाई मैंने तो अभी incision ही नहीं दिया था, where is my fault in this? And this is not a very uncommon scenario. He said that now the further thing, whatever is there, you talk to the anesthetist, and the case should go to the anesthetist, not to me, because I have not given even the anesthesia. So that is where the contradiction will be there, and it should not be there, because legally speaking, it is most of the time it is the surgeon who is selecting the anesthetist. It is not the patient who is selecting the anesthetist. So even if it is the anesthetist issue, surgeon cannot get away just by saying that मैंने तो incision भी नहीं दिया था. So it is better that both of them work like a team, and whatever is there, they try to explain up the things in a proper manner, whether it is to the patient and patient's attendant outside, or into the court of law if it goes to the litigation. And then, like I said, it is better that we have a reliable group that we can call the anesthetist, the second anesthetist, if required, should be in such a way, because I scratch your back and you scratch my back. It is a mutual understanding, so that if the emergency has occurred, he should cancel his routine cases and come for the help. It's not that I have a long list and I cannot postpone that. You can postpone that. And in your reliable group team, you should have a physician, you should have a cardiologist, and you should have a surgeon of whatever surgical varieties he's having. Another thing is, most of the time, the people say whether, if it is occurred, whether we should go for postmortem or not. A common understanding and common thinking people say, no, the patient's attendant did not want the postmortem, so we have written that they do not want the postmortem. That is not, that is just a placebo effect. That is not a legal excuse. If it is an unnatural death, except for in the high risk cases where you feel that, okay, the patients and the patient's attendant are understanding and is not going to create a problem, and moreover, you know the cause of death, that it was in there, so it is acceptable from all front, and you don't anticipate 100%, nobody can be sure, but 90% or 95% you feel that it will not create a problem, probably you can get away without getting a postmortem. Otherwise, you have to ask for a postmortem. Now, asking for the postmortem, you just have to inform the police that such and such unnatural death has occurred in this situation, so kindly do the needful. Once you have informed the police, it is the responsibility of the police. If the police comes and ultimately maybe the patient's attendant have taken some sort of understanding with police and they do the panchinama and give them without postmortem, they hand over the dead body, it is beneficial for you, in the sense that if there is no postmortem, and the responsibility of the postmortem, not doing a postmortem, is not on you, but it is because of the panchinama by the police and the patient's attendant, then whatever hypothesis about the cause of death that you would give, whether it was a cardiac arrest because of XYZ reason, or it was an anaphylaxis because of some XYZ reason, that will be accepted, because that cannot be challenged because there is no postmortem. So that will be good for you. But if just by saying that the patient has written in the case file that we do not want postmortem, may have little bit of moral value, but it will have no legal value. That is, I said, return refusal has no value. Now, if, say, for example, if you have been able to revive, and obviously that time you are putting an EMBU and you are not having a full ventilatory support and you are not going to have an ICU, obviously you have to refer it to a higher center. So, shifting a patient is another very, very critical situation, and there are few protocols that must be followed. A government hospital cannot refuse to take a patient, and then whatever, whenever you are shifting a patient, it is better that you contact the persons wherever you are shifting the patient, and you have to discuss with the attendants and tell about the situation and the counseling, and take their option. What options, where do they want to shift the patient, whether they want to shift to some government hospital or some corporate hospital, or wherever they want to shift the hospital. In that hospital you should contact and take their consent that okay, we are sending the patient. It should not happen that you send a patient to a corporate hospital and they refuse to accept the patient and a precious time is lost. And then patient must be shifted in a well equipped ambulance. This is one particular case where LSCS was done. The blood turned dark. Obstetrician informed the anesthetist. Patient needed resuscitation. ET tube was passed. Then ET tube was removed because of the fear of the bite. It was shifted to ICU. The patient became vegetable because of the brain hypoxia. Now, here was the problem. The anesthetist did not accompany the patient in ambulance. His problem was that if he goes into ambulance to a corporate hospital which is 5 kilometers away, how will he come back? So he followed the patient ambulance in his own car. Say, anesthetist in his own car following the ambulance is of no use. He has to be in the ambulance so that in case of there, he can monitor the patient. If oxygen is to be given or whatever is to be given or whatever help to be done, that he can do it there inside. And another thing is whether you do or you do not do or whether it is there or not there, at least your attempt is seen because law is very clear. Law feels very clearly that law is not expecting you to be the best in the world or best in the country or best in the city. But law wants you to do your best. If you are following this in your own car, in ambulance, that means you are not doing your best. And law also accepts without any hesitation that your best may not be good enough. Ultimately, the patient may succumb, patient may not survive, and the blame will not necessarily come to you. But if the attempt is not shown properly, then there is a problem. So in this particular case, the anesthetist was fined. Then I said about the documentation. Very, very important that the documentation should be there about whatever is the required pre-operative workup for that class of patient. If he's a young patient, naturally an echo and all that may not be necessary. For each and everyone, you know much better than that I can tell you about what is the pre-operative workup required. And very important that the pre-anesthetic checkup note should be there. It is very, very important. Commonly, we see in a small nursing home, the patient is taken inside, the anesthetist comes, does whatever he wants to do, finish the case, and before the patient is shifted, he goes out. And there are practically no notes for the anesthetist. That may happen unless until it is put into trouble of the litigation, there would be a big problem. And then what are the operative drugs are given and whatever are the suggested your post-operative care, the anesthetist note should be in a proper manner. Another thing is whenever we are doing the record, it is very, very important that the record should not only be prospective, but should also appear to be prospective rather than retrospective. Most of the time we see that our records are in a retrospective manner when there we are writing all the notes in one flow, one handwriting, one ink in a similar manner, all for every time. And then there have been cases where the court has written that if the record is too perfect, It is an afterthought and later on written. It is not the normal practice among the medical practitioners. So your record should not become too perfect, number one. Number two, it should not look like cooked and manipulated. And it should not be in the same handwriting with the same pen and same ink in one flow. Another thing is, like I said, records are the most important document, and especially the valid informed consent is the most important, single most important document as far as the surgical death on operation table, etc., is concerned. Another thing is the judges. We know that it all depends on the tug of war between the lawyers, what the judge will decide on whatever is presented to them, the matter presented by one lawyer and by the other lawyer. If your lawyer is going to present the records in a proper perspective, and it is very, very important that the doctor should not leave everything on the lawyer. He should always see what the preparation of the records are there, what are the answers which are being given. It should be scrutinized by the doctor himself, and ultimately required, it should be improved by them and edited by them. In general, what happens is that the case goes on for about 3 to 5 years at one level, district level, maybe 3 to 5 years at state level, maybe another 3 to 5 years at national level. So it may take about 10 to 15 years for the final judgment to come out. And in that time, what we will see is that your notes written or your comment written and signed by you, an earlier one is different, and then what you are writing after 3 years is different. So it is very, very important that whatever you are writing and whatever you are signing, you should have one copy. You keep it in your record. And next time, whenever you are writing, at least you should read the previous records and this record to see to it that there is no contradiction. Another thing you all may be knowing much better than in the CPR. Of course, as I remember long back, it used to be that at least you should do for more than half an hour CPR should be there. And probably nowadays the things have changed, and you probably that how long that minute will be there, I may not be the proper person to talk about how many minutes CPR should be there. But say, for example, it was for 30 minutes CPR to be done, and your document are saying that the patient got arrest, there is no pulse and no BP at 12 o'clock. You started CPR, and at 12:10, you have abandoned the CPR and certified that the patient is dead. That means it is not CPR done with the recommended minimum classified time. That should be there because your record should not contradict your own thing. Then another thing is a very of the practical social thing that we should have our a reasonably good rapport with the area police, area politicians, and the press. Because many times it happens that maybe you have been able to explain the things to the patients and their attendant, but some local politician, chhot bhaiya neta, will come and disturb your situation. At least don't have the negative report. If you have a negative rapport with one of the so-called politician or press or the police person, in such situation, it will create more problem. And it is very, very important, like I said, that we should have the surgeon and the anesthetist should have a good rapport with each other, and they should not contradict their own statement. And then another thing is very, very simple: the old timers and the new generations. The like if you remember the old timers previously, maybe about 30, 40, 50 years ago, if there was an income tax raid on someone, it was looked upon, it was not taken as a status symbol and all that. But in nowadays, if there is a raid on one income tax on someone, it is not taken as a bad thing. Okay, yeah, fine. Then probably that has become status symbol also. So we all the people who are old generation people, if there is a litigation against us, we do not like it. We don't like it, and we feel it as a personal attack on our skill, our experience, our knowledge, our dedication, our sincerity, whatever it is. But the newer generation that I have seen in last few years, चलता है केस हो रहा है ना हो रहा है चलता है कोई बात नहीं lawyer is there, he will take care. So they do not take it to the heart. So they probably have become thick-skinned money-making robot It all depends where do you find yourself as. So there are a few cases that I will let you know. Death during operation LSCS. The surgeon had told the patient and their attendant that surgery would be over in half an hour. The blood is not needed, so the blood was not arranged. But the 5 hours were lost in operation theater. Then patient was serious and it was shifted and the patient died. And of course, the postmortem showed the shock due to abdominal hemorrhage. So this was the particular case. This was another death following hernia surgery, and there is a room for improvement. Hernia carry a significant mortality in elderly and unfit patients who require close attention to perioperative management. These patients should be anesthetized and operated upon by the consultant staff and during the normal working hours. I have seen many people operating the cold cases at 10 p.m., 11 p.m. in the night because they are busy for something else or operating more cases at some other hospitals during the daytime. So at some places they are operating at 9 p.m., 10 p.m., 11 p.m., which is a cold case, which should be strongly discouraged. Another thing, another anesthetic practice that I have seen commonly is that one anesthetist is managing 3 operation theaters, which is, in my opinion, not proper, certainly not proper. This is about the poor pre-operative preparation. This is the Rashmi Fadnavis Mumbai Grahak case. It was an obese patient. She was complaining of excessive bleeding. The blood group was A negative. The surgeon had taken this patient not to a central place, but in a very remote place in some very small nursing home. Then they had not arranged the blood. They have done only the cross matching of the blood, while the blood bank was far away. There was no machine operated respirator there. And even for it was an obese patient. So to do intracardia, the suitable long needle was also not available over there. So these things were all documented and found as a negligence. Well, this is a very common sentence, does not make any sense. For the prevention, we must have our checklist. And in checklist, what I have seen is that, of course, the WHO has given a very exhaustive checklist of at 3 stages, 28 checklists and all that. But at practical level, in some of the institutes and the corporate hospitals, that may be practiced. But in most of the places, in the small nursing homes and all that, the only checklist that I have seen, which is being followed, is कि छोटी चेक कर ले पैसा जमा हुआ कि नहीं. That has been the only checklist which has happened. So we must have a checklist, PSE, pre-operative counseling, informed consent. We must do a weekly checkup for the emergency tray so that there is no emergency adrenaline, expiry date things are there. And then we should always keep one spare oxygen cylinder which is full. And it will be better that it is never to be used. It is always changed. And then see to it that our suction is working. And then, like I said, half death in operation theater, not of the half death where we have been able to revive the patient. That is one variety of half death. Then there are another half deaths. Like everything has happened so far. It's not that it has not happened. And there are many, many recorded cases. Fire in operation theater, explosion in operation theater, OT light falls on the patient, patient falls from the table, the bone fracture while shifting the patient from table to trolley or trolley to the table, and these all will fall into the negligence. And one of the very important thing that we all must understand that if it goes to the litigation, it is CPA, it is a Consumer Protection Act, it is not Doctor Protection Act. So the bias is always tilted towards the consumer. I'll just give you an example, a very simple thing. Say, for example, you are driving your Mercedes at a very nominal speed of maybe 30, 40 kilometers in the main road itself. And then one rickshawala fellow comes from the side lane and he bumps against the side of your car. Obviously, by any logic, it is his fault, not your fault. But his chakka has got bent And you think about the 15, 20 onlookers which will get collected over there, what they are going to say. They would say, अरे डॉक्टर साहब आपका वो गरीब का चक्का बैंड हो गया साहब, इसको 5,000 दे दो. They are not bothered कि Mercedes is going to charge you more than 1 lakh for that small dent and all this. The similar situation is there. The attitude is there in courts, and especially the lower courts. They have a feeling the doctors are making minting money, doctors are looting money. Moreover, it is not the doctor who is going to pay, it is ultimately the insurance company who is going to pay, and the poor patient has already lost, so give some compensation like this. Though it is said that the burden of proof is on the complainant, but most of the time the judges there, people sitting on the judgment chair, they play like the 12th man and the 13th man or the empire. So the take home message will be honest to yourself and your patient, keep good medical records, always take informed consent, have requisite qualification. Another very, very important thing is about the qualification. If you are not qualified and you are doing and you are saying that you are such person, that means it is a negligence per se. If you are not a qualified anesthetist, or even to an extent that if you are not registered in the state medical council as anesthetist, you are registered only as an MBBS and not as an anesthetist. So in one of some of the cases, it may be negligence per se, and you would be faulted for the negligence. Another thing is don't take case beyond your capability. Another thing is don't take case beyond the capability of the setup. Like I say, for in my example, I can do the best TUR in the world probably, but I have a small nursing home of 10-bedded hospital. I do not have an ICU. So if I have to do a TURP on a patient, say for example, who is having 20-25% ejection fraction, who may need a cardiologist and the post-operative cardiac care and all that, and if I am operating on my nursing home, it is a negligence per se, and I should not do that. I should take that patient to a hospital where the cardiologist is there and cardiac ICU facility is available. And don't take any case without full workup, and do not hesitate to take second opinion, need to convert, need to open, need to refer. And another thing very important, cover yourself and hospital with professional risk management or indemnity insurance. And please prevent preventable surgical errors. Thank you. Thank you very much.
Thank you very much, sir, for your enlightened enumeration about the topic, which is very horrifying for the anesthesia community and for everybody who so gets it involved in that, whether it is a surgeon or nursing home, everybody is there. So, yeah, I think you can continue with your second presentation, and then if there are questions, we'll take in the end.
Okay. Okay. Doctors and litigation, that means how to defend your case, medical negligence case, it is there, how to proceed. Well, this is a very common sentence. Honesty is the best policy. But we all know it is commonly said everything is fair in love and war. I believe very strongly that everything is fair in love and war in CPA. Because in general, no doctor wants to harm his patient. When we joined the medical profession, we never thought that we will have to go through all these things. 30, 40 years when we joined the medical profession, that we will be under litigation. And when the matter goes to the litigation, we can understand that then we have to win the war at any cost. So that time we need to take care of everything. Then we must follow this Chanakya Niti, Sam, Dam, Dand, Bhed. And even if it is said that the offense is the best defense, if required, we can go ahead in that and take that. But say, for example, if your case has a very weakness, clear cut, It is commonly said in China कि निर्बल राजा को तत्काल संबंधी कर लेनी चाहिए. It is say, for example, a laparotomy has been done, not exactly related to the anesthetist, but if it is laparotomy has been done and a mop has been left, which has been proved beyond doubt, has been operated and documented and removed at third place, then there is no defensible thing. It is a non-defensible thing. So you should do out of court settlement to whatever extent is possible. Uh, about 10 years ago, in one of the urological meeting in Kochi, of course, the sample size was about 130 or so. It was a small gathering. I had taken a survey. Have you been involved in some way or the other in medical negligence issue, either notice or court case or the medical council complaint? I was expecting it to be around 8 or 10% because these were for the specialty of the urologist and a very, very senior urologist and experienced urologist. And to my surprise, it turned out to be 36%. And this was more than 10 years ago. Upchar had taken one survey and the sample size was around 1600. And this was about 2-3 months ago only. Have you ever faced a complaint from your patient in any consumer court or commission? And again, it turned out to be 39%. That means it is on a very, very high one. But again, it's very simple that every complication is not a negligence. But we have to understand that just because it is a negligence, you cannot say that this is not a complication. This is not a negligence. Just because it is a complication, you cannot say that this is not a negligence. The complication can be associated with the negligence also. So if that complication has occurred and matter goes to the litigation, it is your duty to see to it and explain that this complication is not because of negligence. Say, for example, I would say that we have done our sufficient preoperative workup in a proper manner so that this doesn't happen. That is one part of it. During the surgery procedure, we have taken care that these things are there. We have been aware and we have been vigilant to see to it that this particular complication has occurring so that we are doing the early diagnosis and the early management, and if required, we refer it to somebody else. And not only we do it, we document it as well. So these things we need to do if matter goes to the litigation. Like I said, it is CPA, not there. Another thing is about the notice. The notice can come from patient, notice can come from the lawyer of the patient, notice can come from the consumer court or the medical council or any other quasi-judiciary bodies, Human Rights Commission or many other commission, or your CMO or nursing home licensing authorities, etc. If it is from the patient or from the lawyer, it is not mandatory to answer, to give a reply to that legally. But it is always recommended that you should give a reply. I recommend always that you should give a broad spectrum reply that I have used all my medical experience, skill, knowledge. I would have had treated him just like my brother, sister, uncle, mother. And if required, if he comes to me, I am willing to help him further. XYZ broad spectrum. We should not give point by point answer to that. Because if you give point by point answer to that, there is a legal dictum that the complainant cannot go beyond the plaint. So if he has written 5 points in this one, in his complaint, then later on he cannot add 3 more points. All right. Lawyers are not that very hardworking people in general. If he has made the notice once, that means he has made 5 points. Say, for example, whether you give the answer or you don't give the answer, or whatever answer you give, if he has to go to the court, the same notice he is going to paste it there. So that these points remain. If you give him point by point answer, and if you are given a good answer, say for example, he will feel that okay, or these 3 points are already gone. So he will put another 3 points in while he's putting to the court of law. And if you don't reply, then he would say, yes, sir, see, this doctor is so careless that he has not bothered to give the reply. So it is better that you should reply, make it as a short reply, broad spectrum reply, not any point giving reply. Like I said, unless until your defense is watertight, you are going to have trouble, especially in the lower courts, because, like I said, the doctors are rich and insurance is going to pay. So, what is the negligence? Negligence is mean that the doctors has a duty, and then there was a breach of duty, that what you should have done, you have not done, or what you should not have done, you have done. And because of that, there is a damage. And the damage should be the proximate cause of the breach of the duty. So if, say, for example, you get the notice from this one, at this one, so very simple thing is there, that you read the note complainant story, you read it once, you read it twice, you read it thrice, sleep over it, get over in the morning, take a good cup of tea, read it again, read it again, read it again. So what we need to do is we have to find some understanding about what story he has given, because nobody knows better than you about the actual story of the patient. You are the best judge. You have the best knowledge about what has happened and what has not happened. Nobody else in the world can ever know better than you. So, whatever the patient's story is there, you have to find fault in that. And because, like I said, you have to win it at any cost. It is not the question of some money only. Say, for example, they give you 10 lakhs, 10 lakhs may not make a too much difference, but it is a question mark on your skill, your knowledge, your experience. So we have to find a chink in the armor of that story. Like I said, the Jacob Matthew case was a professional may be held liable for negligence in one of the two findings. Either he is not possessed of the requisite skill which he professed to have possessed. That means he is not a qualified anesthetist and he says that I am an anesthetist. If he is projecting like that, and if these things are documented, brought about by the complainant's lawyer to the notice, the further whatever treatment has been given or not given is not important, and the doctor is negligent per se. Or he did not exercise the reasonable competence in the given case, the skill which he did not possess. Like I said, he does not necessarily have to have the best of this one, but he should be of the average skill of the anesthetist. Like I said about, already said about the Martin D'Souza and this one. And when the expert opinion is taken in this Kishan Rao and Nicholas University Hospital, what is the duty of the expert when the expert opinion is taken? The duty of expert is to explain technical issue as clearly as possible so that it can be understood by the common man who are sitting on the judgment chair. On the judgment chair, it is the common man who is sitting who does not have the medical knowledge or legal knowledge. Previously, the consumer court did not necessarily have the doctors or the medical professionals, but at least the president used to be from the legal background, high retired high court judge or this one judge. In CPA 2019, even that has been done away. So now it is possible that all the members of Consumer Forum will be from some other background, not from the medical background and not from the legal background, but they will be deciding on the medical legal aspects. And that is the situation in Indian law. So the expert should assess the fora in deciding whether the act of omission constitutes the negligence. Another thing is that the fora is not bound to accept opinion of expert witness in all the cases 100%. There have been judgments where the court has not accepted the expert opinion of AIMS Delhi of the board where there were 3 doctors. Even that board opinion also they have not considered. So negligence is the breach of duty exercised by the omission to do something which a reasonable man would do or something which a prudent and reasonable man would not do. It is the essential ingredient of the offense. Negligence is to be established by the prosecution, not merely based upon the error of judgment. But as far as the death on operation table is concerned, the things change because the death has occurred itself. He has discharged his duty. Because in the 4 wall of the operation theater, the patient attendant have no access. So it becomes the duty of the doctors, surgeon and anesthetist, to explain the sequence of events, what has happened, what was done, what was not done, in that particular situation to the satisfaction of the people who are sitting on the judgment chair. In the realm of diagnosis and treatment, there is a scope of genuine difference of opinion. So one may have one school of thought, one may have another school of thought, unless until it is the 13th century school of thought, that is all acceptable school of thought. There is no problem in that. Medical profession is often called upon to adopt a procedure which involves the higher risk of element, but which he honestly believes that providing the greater chances of success for patient rather than a procedure involving the lesser risk. This is in the high risk patient where you think that trying this may be more risky, but it will be benefit. So there is nothing wrong if you take this one. Merely because doctor chooses one course of action in preference to other, it does not become the negligence. It would not be conducive to the efficiency of medical profession if no doctor could administer the medicine without a halter round the neck, so that the judiciary is accepting that we need to protect the doctor against the litigations, unnecessary litigations. It is our bounden duty to obligation of the civil society to ensure that the medical profession are not unnecessarily harassed or humiliated. Like I said, standard of care has to be of the average. This one, you don't have to be a super anesthetist, but a average anesthetist. Now, whenever we are giving our supportive literature documents in support of the treatment, that what we have done, what we need to give is, number one, whatever we have done as per the documents in the medical record, we have to give the medical literature in support of that, that the textbooks or the other medical literature are giving that this is the universally accepted practice for this particular situation, and whatever we have done is not unusual. And that is, we have followed the standard protocol and standard practice. That is number one. Number two, we should always give the expert opinion. If the anesthetist problem has occurred or the surgeon problem, whatever has occurred, of the same specialty, we can take the another expert's opinion that in the given circumstances, this is the standard protocol, and this is what even I would have done that. And even with the expert opinion, he should attach the medical literature that the textbooks are also saying the same thing. So that will have a stronger weightage. And like I said, of course, your records have to be good. There is no denial. If the good record is there, it will give good record defense. Poor record is naturally poor defense. And no record, God only knows. In anesthesis, this consent form, like I said, one of the most important thing is the consent, valid informed consent. There are various informed consent per se is a full talk in itself for 1 hour. I cannot go into that much detail, but it is said that it should be in the patient's language so that it is understood by the patient. So even if it is not there, like in my own consent in my hospital, it is not like this. But what I take care and ask the patient, in one line is written in the patient's handwriting, हमें बीमारी बेहोशी और ऑपरेशन के बारे में विस्तार से बताया गया है. If the patient is writing in his own handwriting this particular sentence, even if your other things are not in that particular language, that will be taken care of that. In one of the cases against myself 4 years ago, I was saved because of this. Because the complainant has given a complaint that the doctor had said that it will be an endoscopic procedure. After 1 hour, he came out and said that no, we have to do an open procedure. They were not told, and at the last moment, we have given this. So that is what I showed in my consent, that it was very clearly written. It can be this or it can be that. It can be endoscopic attempt will be done. If it is not done, it will be an open procedure. And they have been given in detail, and their handwriting, this particular sentence was written. So the case was dismissed immediately on based of this only. Another thing is about the good discharge summary. This is not for the DOT, it will not come. But whenever we are giving, say, for example, a discharge summary, it is a very common thing and in the mind of everything and real fact also, that a discharge summary will go with the patient. while the indoor case file remains with the doctor and the hospital. All right. So, as an afterthought, later on, the handling of that, manipulation, addition, deletion are possible into that. But if your discharge summary is given to the patient, whatever you have written in that, that becomes a gospel truth. That cannot be questioned. Each and every word written in your discharge summary can never ever be questioned, because you cannot to go to his home and change the discharge summary. But the good discharge summary should write detail. We should not hesitate to write details about this. Many times, what we have found is, especially in the surgeons, that they would say, okay, the hernioplasty is done. I suggest them that you should write all details about various steps of the hernia and all this and that, because the people who are sitting there, they do not know. Another thing that I have been insisting and recommending is the discharge consent. Discharge consent is something that I would be showing you here. It is something like this: that I hereby certify that discharge summary investigations have been given to us, nature of problem, prognosis, plan of management, treatment given in the hospital, possible complications, failure, need for regular follow-up precautions, possible follow-up and procedures have been explained to us to our satisfaction. Discharge consent is not a proper terminology, but I do not have a better terminology, so I still use that. So if the patients are writing in their handwriting and signing this at the time of discharge, they cannot say that this was not told to us, not explained to us, and all this. Another thing is very, very important, that all our prescription, either OPD, discharge, or follow up, should always end. The last line should be review after whatever period you can write oblique SOS. In one of the cases against one of the very senior national prominent urologist, the court has given a negligent decision because he had not called the patient for review. The last line was not review. Lithotripsy was done. Patient had some infection. They have given some antibiotic and verbally told to come after some time. Patient was not satisfied, went somewhere else, got the further treatment, and later on went to the court. So the judgment written, the exact words are that the doctor and the hospital abandoned the treatment without completing, while the patient did not abandon the treatment. So you should always write review. Well, of course, for the anesthetist, you do not need to write that. But for the defense, it is very, very important. And moreover, the patient coming for review is a financial viability. He will come and give you money. What is the problem? Like I said, it is very, very important that the communication should be very proper. Sir, the doctor is very busy. If you see the diary of a lawyer, the diary of a lawyer is much more bigger than our operation list. And in general, 8 o'clock, at 10 o'clock, he will go to the court. 5 o'clock, he will come back. Then he will freshen up, have a cup of tea or something like that. And 8 o'clock, he will come back to his office. And then he will open the diary and see. Okay, this many case, this is not possible. He will take a date, next date, and all this and that. And where it will be caught, no, 3 times we have already taken a date, we have to take for that. Then he would prepare and do something. So that means he is not able to give sufficient time and energy to that. And most of the time, I have seen in my practical experience that the answers are being prepared. Their ward boy will come or their assistant clerk will come, and the doctor is busy in one operation theater, one case. In between the two cases, he will come out and sign without reading. So he does not know what he has written and what he has signed. So it is very important that a prior proper communication should be there, proper discussion should be there, a provisional answer should be prepared. The doctor should see to those answers and make the necessary change, because the court is going to decide on the matter what is presented to them. So that is what I said. It is very important that don't contradict your own statement. And another very, very common situation nowadays, which is occurring, is when the people are learning, complainant and their lawyer, that they are making everybody as a party. They will make the party surgeon as a party, anesthetist as a party, hospital as a party, physician as a party, cardiologist as a party. And maybe if there are two anesthetists involved, two anesthetists as a party. So multiple parties are there and they do not have time to correlate the things and their answers, and there is a contradiction. So that against goes the doctors. And then I said it's very, very simple thing. Like I said, it is the people who are sitting on the judgment chair or the lay persons. All right. They may not be knowing about the medical profession or the situation and all that. And we in general, the doctors are very shy about singing your own song. And it is very, very important that when the matter goes to the litigation, in your OPD, you may not sing your song. In your OT, you may not sing your song. But when the matter goes to the litigation, you should sing your song without any hesitation, because they do not know how hard work you have done to reach to that level. You need to explain them very clearly that after 12 you go have to appear for the NEET or PMT exam. So many people are appearing for the exam, very few are selected. Then after 5.5 years you become an MBBS, and then again you are on the street. Then again you have to knock the door of the PG entrance exam. So many people appear for the PG entrance exam and so many people are get the entrance exam, and then they come out and do the practice. And after that, so many years of experience is there, so many of the cases that you have done. And moreover, the patient has not come to you just like that from the street. He has not, you are the first shop, so he has come. He has inquired about your reputation, your experience, and all that, and then only come. It is very, very important that you should give this documentation in a proper perspective. Don't be very short on that. Give a reasonably detailed one. Sing your song. Don't hesitate to do that. Now, I'll just give you some examples. Like I said about finding the chink in the armor. This was one of the cases here. If you put this here in the Google, because it's a state forum judgment, you will find that. In this particular case, a ureteric stone, lower ureteric stone was operated by ureteroscope and a laser things were done. Later on, after 2 days or so, the patient has some pain or something like that, and doctor was not satisfied. So after 2 days, he took back the patient again in the operation theater, did the ureteroscopy, saw that everything he felt was fine. He put in the stent and came out. Later on, after third day, fourth day, patient had right iliac fossa, some pain. There was little bit of tenderness. So assuming that it can be query appendicitis, the general surgeon was consulted. General surgeon said it appears like an query appendicitis. So he put their antibiotics and all that. In 3-4 days, the patient improved. There was no swelling, there was no tenderness. Patient became comfortable and the patient was discharged. After 3 days, he got admitted into another hospital, another corporate hospital. There, assuming that it is a query appendicular abscess, they did a laparoscopy, and there they found that the appendix is normal and it is basically a retroperitoneal abscess. So a cystoscopy was done and a retrograde pyelography was done, and they found that the lower half of ureter is missing and it is a retroperitoneal abscess. Naturally, they did whatever drainage of the abscess, and then they did the transureteroureterostomy and treatment, etc., whatever was done. And then, of course, the litigation was put against Dr. Sanjeev. Now, when the matter came here, and he being our friend, we went through the documents. And like I said, we read the story again and again and again. We saw the discharge ticket of that hospital. We went through our records once, twice, thrice, not only 1%, 2%, 3%. And then we could find a chink in the armor. We were able to find a one big day. There was a gap of 3 days from discharge of this hospital and admission to the next hospital, number one. Number two, our discharge paper and a sonography on that day of the day of discharge was showing that there was stent in situ. Ureteric stent was very much there. But the first sonography at the new hospital on the first day of admission did not show that stent there. So we put forward a hypothesis that it is possible that in between, because of whatever reasons, he had gone to some third hospital where he has got his stent removed. And while removing that stent, the injury has occurred and it has caused the further things about the loss of the ureter and the retroperitoneal abscess. And it is not because of the primary surgery. And this is the same which has been mentioned in the judgment. So that is what I'm saying. You have to find a chink in the armor. Very, very important. Next one was this is a case of Dr. Ajay Gupta. He's a skin specialist. Like it happens many times that the doctor's relatives, friends and relatives, they take it very lightly and they do not attach the consultation in a proper manner. They will take an appointment, will come to the OPD clinic and all that. They may be probably at the while you are doing a shopping of the vegetables, they would do the consultation there itself or something like that. So that patient also was doing consultation like that, and he had the glandular wart, penile wart. So he has given him the podophyllene and all this, and then told him to come back every week so as to see that. At that time, he will be coming to the OPD, not paying this one, but maybe when he is coming out from his OPD time on the street, he's meeting. But doctor used to take him in the chamber and see once or twice. Many times it was only on the street. Then he saw that 5 or 7 children were there. Later on, that patient went to somewhere else. There they did the biopsy. It turned out to be CA penis, and the treatment was done. And then he filed the case against him, litigation. Now, again, here the same thing was there. We were able to see that we found the records and all this. In OPD, whenever he was discussing on the street, he said a different thing. But in outpatient, our outpatient record showed that he had come 8 times. And the paper that he had deposited in the consumer quorum was 7 times. So one prescription he was hiding. And as per the OPD record, that was the second prescription during his second visit. And in first visit, when he was there, it was written very clear cut, there is a history of extramarital contact. So we put forward the hypothesis that in the second visit, he was advised biopsy, but because the patient got afraid that his history of extramarital affair will become very clear, so he avoided doing the biopsy, and not only avoided doing the biopsy, even when he put the case in the court of law, he had hidden that particular prescription paper. And our OPD records were able to show that and prove that. So the court does not like anything is which is hidden from the court. That simply means that the complainant has not come with the clean hand. This is a legal dictum. If you are not come with the clean hand and you are trying to hide something from the court is going to take a very strong view against you, and that is what it was taken. Then it is, in this particular case, like I said, ensure that the consent form is filled by one person in one ink and one sitting. It is very, very important. In this, it was not there. So the judgment says that it may be probably a manipulated one. Like I said there earlier also, in this particular case, avoid writing abnormal, lengthy, or explanatory medical record. The judgment has written it was not indicative of normal procedure and it was maybe afterthought. In this particular case, it was take the expert opinion from the doctor with the higher qualification or higher experience. So it is better that you take from a senior person who has a higher qualification or he has a higher experience. If possible, if it is not there, that's okay. Then even the friends and colleagues can do. And like I said very clearly, in this particular case, it was mentioned, you should collect the medical record, check, recheck, and then prepare your defense and cross-check your defense writing again and again. Check for inconsistency between the medical record and the medical defense. You are writing defense is something else, while your medical record are showing something else. So that means you would be in trouble. And this particular case, the expert evidence was taken by somebody else. Court rejected the evidence because the patient was a neurological case and expert evidence was taken from a gynecologist. So you have to take expert opinion from these same specialty people. And it is very important that the consent should be taken after counseling, because consent is not a single step signing the document. It is the continue a dynamic process which starts with the counseling from the OPD procedure or the first meeting with you. And then they should give enough time to contemplate and withdraw this one if they want to. And say, for example, this is another very simple way of defending your case, where probably a case which has gotten infected or and has an infective complication. And there, if you are able to show that the proper record of efforts taken for sterilization of your operation theater, and if you are by your OT record, you are able to show that in that particular day, we had operated 4 cases or 5 cases in the same operation theater, and none of them have got complication of infection. So this particular infection is not because of the deficiency of the operation theater or sterilization of the operation theater, but because of the patient's condition or inherent condition or his own body's ability to handle the situation. Thank you. Thank you very much for the patient listening.
Thank you, sir. Thank you very much for taking so much elaborate, informative discussion and about the death on the table, plus guidance and so many case reports you have covered. So I think if there is any question, I don't see any in the chat box. There is only one about the perfect notes is not the best idea, you said. But it is missing point in notes with another pen and noted down later also considered not a good idea.
Yeah, correct.
Okay, so if anybody wants to have any question.
So I have a question.
Sure.
Yeah, please.
If the patient's general condition or say the cardiac index is not good enough, and we have explained them that there are chances of death on table, and if patient dies on table, then do the court will accept that we have explained death on table? Is it in our safety?
Yes, yes, it is in your safety. It is in your safety, because then you would be taking even the high risk consent and all that must be taken. And then see, while you are talking with the patients and attendant, I am sure that you are able to judge that whether they are going to create a problem or not. If there is any doubt of creating any problem, then it is better to get a PM.
Thank you.
But if in general you feel that most of the time you would feel that the patients and they are understanding, they are accepting that the high risk things are there and it will not create a problem, then probably you can get away without doing a postmortem.
Thank you.
Actually, you have already explained it about the postmortem. You should leave it to the police. Don't take any decision on yourself.
Yeah, it is much better.
Yeah.
If we can give the definite cause of death on table, is it necessary to go for PM?
See, the problem is if the matter goes to the litigation, your definite is not definite, na?
No, if we can give the cause of death, definitely.
No, I understand that you will give the cause of death, but they would say, no, this is not the cause of death. The litigation is only your words against the other words. Yeah? That will be the problem. And then you would not be able to prove without the postmortem. You would be able to give a definite cause and 100% that would be correct. But when the matter goes to litigation, if it is not going to the litigation, no issue. If it goes to the litigations, they would not agree with that.
So in that
Understand very clearly.
in
Three
that case,
cla-
in that case, every death on table should be informed to the police, and we should insist for postmortem.
Sir, that is what I said. Many times you have to take a balanced view, play with the ear and all that. You feel high risk was there. You have explained all this and that. You don't anticipate any social problem or litigation. You can get away with that.
So if we inform the police and ask for the postmortem, and the patient refuses, and police doesn't,
That is good. That is
if
that
police
is
doesn't go for a postmortem, then what
that
is
is
our
that is
responsibility?
the best possible solution for you. Because then your hypothesis will not be questioned. Whatever hypothesis you will give, nobody can question that.
Actually, it is the police to decide whether to go for postmortem or not. As sir has already said, police may decide to go for Panchnama and hand over the body. So if the liability shifts from you to the police, then if anything is doubt is there, they can put a case against police, not against you, because you have done your job. Am I correct, sir?
Yeah, absolutely.
So thank you very much, sir, taking out
Okay.
time, and
Thank you.
you are busy. Thank you all.
Thank you.
And
Thank you very much.
okay.
It was a pleasure and honor. A wonderful, thoroughly enjoyed that. Okay. Bye.
Thank you, sir. Thank you. Yes. Yes.
Hmm?
No, sir. Somebody is saying hello. If somebody want to say anything, you can unmute yourself and speak. I think you have given so
Yeah.
elaborate coverage that there's no question. Okay, sir.
Okay.
Thank you.
Okay.
And
Thank you. Good day.
good night.